Yes, yes, sir. It is just going live. Just starting in 2 minutes. Yes. Mm, Just a second. Mm, Yes. Good evening, everybody. Welcome to yet another session on White Army. We are indeed privileged to have with us Dr. Ashwini Modi, ma'am, who is a consultant laparoscopic surgeon from Rajkot, Gujarat, to take a clinic on a laparoscopic repair of inguinal and anterior abdominal wall hernia. I invite each and everyone to the session and welcome to you, ma'am, and over to you, ma'am.
Good evening, everyone. First of all, thank you for listening us even on Saturday evening. So today we are going to discuss on laparoscopic repair of inguinal and anterior abdominal wall hernia. So first of all, who is the father of modern day hernia surgery and why it is modern day hernia surgery? Because we are using laparoscopy now. We are not doing it on an open basis. We are doing it, but preferring laparoscopic surgeries in these days. So he's the man who found this laparoscopic and bring this modern day hernia surgeries in this world. He's Edward Bessinis. Right. So which are the abdominal wall hernia? That can be anterior abdominal wall hernia. It can be a groin hernia. It can be like this abdominal wall hernia. That can be a groin hernia. That can be a pelvic hernia, and that can be a posterior wall hernia. So in groin, you will have indirect inguinal, direct inguinal, and femoral hernia. Right. In anterior abdominal wall hernia, you will have umbilical hernia in center, above epigastric, below hypogastric, or spigelline hernia. In pelvic hernia, this pelvic cavity also we have few openings or few spaces where the wall is quite weakened. So from that side, you can have an hernia that is an obturator hernia, sciatic hernia, then this perineal hernia, right? Three things can happen. And in posterior wall, from posterior wall, you'll have this lumbar hernia. It can be superior lumbar and inferior lumbar hernia. That calls Reinfeldt's and Petty's hernia. So today we are going to discuss about the anterior abdominal wall hernia repair by laparoscopy and the groin hernia repair by laparoscopy, mainly indirect and direct inguinal hernia and ventral hernia. That is, we are going to discuss today. But before discussing anything, we should be knowing the basic anatomy of that thing, that pathology. So if you are not knowing anatomy, how will you repair that thing? So first of all, you must be knowing the anatomy. So we are going to discuss first anatomy, surgical anatomy of inguinal canal. So what is inguinal ligament? It is also called as Paupett's ligament. It is formed by the lower border of external oblique muscle, that is aponeurosis. First, this external oblique muscle of anterior abdominal wall comes down, become an aponeurosis, and it will fold back and forms inguinal ligament, right? Extends from the ASIS, that is anterior superior iliac spine, to the pubic tubercle. What is inguinal canal, which is we are going to repair later? Not the canal, but that canal from around the canal, the pathology is happening. So we should be knowing inguinal canal as well. So that is an oblique passage in the lower part of abdominal wall that is 4 centimeter long, situated above the medial half of inguinal ligament. If this is the inguinal ligament from ASIS to pubic tubercle, this is pubic tubercle, this is ASIS, and so this will be the inguinal ligament. So inguinal canal will be just 4 centimeter of this. This will be inguinal canal from pubic tubercle to 4 centimeter lateral. That will be between superficial inguinal ring and deep inguinal ring. So what is superficial inguinal ring and deep inguinal ring? We should be knowing that also. So superficial inguinal ring is a triangular opening in external oblique aponeurosis that is 1.25 centimeter above the pubic tubercle. And what is the deep inguinal ring? That is U-shaped condensation of fascia transversalis lies 1.25 centimeter above the inguinal ligament midway between the symphysis pubis and the ASIS. So superficial, we call superficial. So it should be on the superficial muscle. That will be external oblique aponeurosis, making the anterior wall of inguinal canal, right? And deep will be the which will be the making the posterior wall of inguinal canal. That should be the deep ring should be in that only. So what muscle or what thing will make the deep posterior wall of inguinal canal? That is fascia transversalis. So that will it will have this U-shaped ring inside it. So deep inguinal ring in the fascia transversalis and superficial will be in the external oblique aponeurosis. Somewhere over here and somewhere over here, right? Sorry, this will be the deep inguinal ring and this will be the superficial inguinal ring. My mistake. In females, this inguinal canal also called as canal of Nuck. So now the boundaries of inguinal canal. So in boundary, we have anterior wall, posterior wall, right? Anterior, posterior, above and below. That will make a canal, like a round canal. It will have anterior, posterior, below and above. So what will be the anterior part? That will be the external oblique aponeurosis, right? That will be the external oblique aponeurosis muscle coming down and making the inguinal ligament. On above, first of all, we'll see the posterior part. That will be the transverse, behind the transverse abdominis muscle, there is a fascia transversalis, right? That will make the posterior wall, right? Fascia transversalis. Above, anteriorly external oblique aponeurosis, posteriorly fascia transversalis. In lateral part of anterior wall, somewhat of internal oblique muscle also forms the anterior wall. No? Am I audible?
Yes, ma'am.
Okay,
Clearly.
should I continue?
Yes, ma'am, definitely.
Okay. So on anterior wall, that will be the external oblique muscle. Here we have external oblique muscle. If you can appreciate, that is going down, making an aponeurosis and making going backward and forming an inguinal canal, inguinal ligament, right? This is an
Yes.
inguinal ligament. This is on the medial part. On lateral part where you are going, there will be somewhat of internal oblique muscle also helps to form an anterior wall of inguinal canal. This is internal oblique muscle. This is transverse abdominis muscle. So on posterior side, behind the transverse abdominis, this is fascia transversalis. So transverse abdominis and fascia transversalis makes the posterior wall. With the transverse abdominis, internal oblique also get fuses and makes a single tendon-like entity that is called as conjoint tendon. That will also help to form a medial part of inguinal ligaments posterior wall. On above, this roof will formed by, now we have remained this internal oblique muscle, right? And transverse abdominis muscle. Transverse abdominis also finishes here, internal oblique is over here. They both get combined, makes a conjoint tendon and forms the roof of inguinal ligament. And now the below, the lower part of a canal, that will be formed by inguinal canal, inguinal ligament itself, right? And the lacunar ligament. So now what is lacunar ligament? We have learned about all this muscle, we know about all these things, but there is the new term lacunar ligament. So what is lacunar ligament? So it is a connection between this inguinal ligament and ligament of Cooper. It is a connection between these two. This is pubic tubercle, this is ASIS, this is inguinal ligament. We have this inguinal canal between this space, but this inguinal canal is connected. This below part is connected with this ligament of this lacunar ligament, right? And it is connected with the ligament of Cooper. So what are the contents of inguinal canal? We should know that as well. Otherwise, how you will define that this is the hernial part and this is the normal anatomical part of inguinal canal? So what are the contents? That is the spermatic cord for the male, round ligament of uterus for the female, and ilioinguinal nerve in both of them. So with lacunar ligament, I spoke about the Cooper ligament. So what is the Cooper ligament? It is the basic thing you can appreciate from the figure as well. That is formed from the periosteum of the aponeurotic tissue along with the superior ramus of this is superior ramus of pubis, and lies posterior to the iliopubic tract and forms the posterior boundary of femoral canal. So femoral canal will be somewhere here. This is inguinal canal. Femoral will be here, and it will be making the posterior wall of it. And this lacunar ligament will connect this inguinal and the Cooper's ligament. So this all anatomy is important because we are going to operate over this site, and we should be knowing each and every ligament, small ligament, vessels, and things passing from this thing. So we do not ligate wrong. We do not ligate at wrong place. We do not dissect wrong anatomy, wrong structure, and we do not harm to the normal anatomy in this place. And we can ligate or we can operate on the right thing, right? So what are the content of spermatic cord? That is also important because while dissecting the sac from the spermatic cord, we should be knowing that the vas deferens should not be ligated, the artery to the vas and testicular artery should not be ligated, and nerve should not be ligated. Why? Because if you are ligating the artery to testis, or if you are cutting the vas deferens, or you are tying the vas deferens, patient will have atrophy of testis later on, or patient will have one-sided. If both side you are making that mistake, patient will have infertility, and if one side, then fertility will be decreased somewhat. Not, I can't say that it will be decreased completely because he is having on the another side, but that is not good for the surgeon to do that without any indication. Ligating the vas deferens is not a right practice, right? So
Yes, ma'am.
yes. So 1 second. Sorry for the disturbance, just wait for 2 minutes.
Yes, ma'am.
Yes. So these are the contents of the spermatic cord. Now, just to revise, this is the inguinal ligament, inguinal canal. We have to look over the structures from here, direct area of direct inguinal hernia. That is the medial part. This is medial, this is lateral. Here will be pubic symphysis. Here will be your superficial inguinal ring. Here will be deep inguinal ring. The deep from the peritoneum or from the abdomen, the structure, abdominal structure will herniate to the inguinal canal, and patient will have indirect hernia, or by the weakness of the posterior wall of posterior abdominal wall, patient will have a direct inguinal hernia that will be also coming out from the superficial inguinal ring at time, or cuff impulse will be felt on the superficial inguinal ring. This is the picture showing that you have most important vessels nearby this ring. So this is danger zone because it have femoral branch of femoral nerve, lateral cutaneous nerve, femoral cutaneous nerve, genital branch of genitofemoral nerve. Plenty of nerves and plenty of vessels are over here. So while operating, we have to take care that we should not dissect any of this structure. We should not cut any of this structure, or while putting a suture to the mesh, or putting a tacker to the mesh, we should not tack this structures. It will create a severe pain, or it can bleed like anything during the intraoperative period or post-operative period, and patient can be get critical while operating. So we have to take care of this two area. We have triangle of doom and triangle of pain. I'll discuss about it later on. So what else in anatomy is important is Hasselbeck's triangle. That is important for direct inguinal hernia. As I said, that direct inguinal hernia is due to the posterior wall weakness. So it will be coming from this posterior wall. So what is area that can weaken and make the posterior wall weak and can cause the direct inguinal hernia? That is the Hasselbeck's triangle. What are the boundary of it? So superficially, supralateral, it is inferior epigastric vessel. There is below is inguinal ligament itself, your inguinal ligament, and medially the rectus, lateral border of rectus muscle. This from this area. Here somewhere you will have the superficial ring also on the external oblique muscle, aponeurosis, and this is posterior wall of your this area. Hernia can come from this side. If Hasselbeck's triangle area will be weak, you will have a direct inguinal hernia, right? There is another term called as myopactineal orifice of Fauchard. So what is that? That is a area having a multiple rings and multiple, not just rings, but that is the area from where you can have direct, indirect femoral hernia. So this is the ring. This is the area where the femoral artery and vessels are here. So you will have from this area you will have a femoral hernia. Cord structure is coming here, so that is your indirect hernia site. You will from medial you will have a direct hernia site. So this ring is showing that you can have growing hernia from myopectineal orifice of Fauchard. So what are the boundary of it? So in boundary, there is medially again the lateral border of rectus muscle, above internal oblique and transverse abdominis as same as in the inguinal canal. Below you will have this pectin pubis, this pubis bone you will have. Now you can't say the inguinal canal because it is covering the femoral also, femoral hernia also. So it will be a pectin pubis over here. So lacunar ligament and Cooper ligament will be covered over here. The Cooper ligament, you can say pectin pubis, you can say the lower boundary. And literally you will have iliopsoas muscle, right? So this is iliopsoas muscle, literally. So these are the boundary: rectus abdominis, pecten pubis, lacunar ligament, this myopectineal orifice. So you have to keep in mind this anatomy also. So now after discussing all this anatomy, basic thing, we'll jump into the laparoscopic repair now, which is the topic of discussion of today. So why laparoscopy? So it is technically demanding to in these days because you will have a smaller incision, you will have a less pain, you'll have less stay to hospitals after laparoscopic surgery than this open surgeries. But laparoscopy needs more experience. So initially, when laparoscopy came into the field, this procedures have sometime less desirable results than the open surgeries. Reasons were technical reasons, that were incomplete dissection due to the less knowledge of anatomy or less experience, missed hernia. Same, you have less anatomical knowledge, then you will miss somewhere something while you are going inside, but you won't see the whole four things or whole this myopectineal orifice, and you'll miss the femoral at times, you'll miss the direct or indirect sometimes. So the hernia can be missed out. Insufficient size of prosthesis can be leading the recurrence, because if there is a large hernia or patient is obese or somewhere and you are putting a small size mesh, that can cause recurrence. And insufficient overlap of a prosthesis over the hernia is the same thing as an insufficient size. You are taking the good or enough size of mesh, but you are not putting on the area where it should be capped, right? So you are going on the wrong side, or you are putting and it is getting overlapped. So it is got rolled back. So it has no point of putting it when it is not covering the hernia side. So that can cause also give undesirable results. Mesh migration, same thing. Improper fixation, and most importantly limited surgeon's experience with the technique can also lead the undesirable results. But nowadays, after many patients, after lots of this studies and practice, surgeons are now doing well, and now this procedures are well indicated. So what are the indications of this laparoscopic hernia repair? Where you will choose the patient, which patients you will choose for the laparoscopic surgery. So in recurrent hernia, where the preperitoneal space has not been previously dissected ever, in that case, you can go for this laparoscopic hernia. In bilateral hernia, you have to, in open surgery, you have to put the big, long two incisions over the both the groin area. Whereas in the laparoscopic surgery, with just 3-port incision, you can operate on the both the sides. So you will choose laparoscopy in same bilateral hernia as well. In patients with the sliding hernia, especially when it is reducible, you can choose this laparoscopic hernia, because in lap tap you are going through the through the peritoneal space. Intra-abdominally you are going to the preperitoneal space, so you can have an excess of preperitoneal as well peritoneal space. And you are putting just 3-port incision in, you can just reduce back the sliding hernia, the bowel, intestine, whatever has slided out, you can reduce it back and you can repair it. So it will have a smaller incision and quick procedure. So we can choose this laparoscopy in that also. And obviously indirect direct femoral hernia we are doing that, and for that only we are doing laparoscopic surgery. So what are the relative contraindication? We have discussed about indication till now. So what are the contraindications where not to choose this laparoscopic surgery, in which patient we have to avoid this laparoscopic surgery? So that are the previous surgery in the retropubic space. If you have operated for any you have dissected in retropubic space for this bladder or for this any female surgeries or anything, so you'll have to avoid it, because there will be many adhesions in that, and while releasing these adhesions you can damage any of the structure, and repair can be insufficient. So in that patient, then intra-abdominal adhesion as well, another contraindication for this. It is a relative contraindication, but you can say you can put it into the contraindication for the laparoscopic surgery. Scrotal hernia as well, because you are not having a proper access to scrotum. And so that is a scrotal hernia is like a direct complete hernia. In case of complete hernia, you should avoid doing this laparoscopic surgery. Few very well experienced surgeons are doing it, so it is a relative contraindication, but better to avoid it. So an incarcinated inguinoscrotal hernia as well, as it is a dirty surgery, you need more access, more access to any organ. In presence of ascites also, so it is also a dirty surgery. In ascites also you have to avoid it, and in bleeding disorder as well, right? So what are the laparoscopic mesh repair present for the this growing hernia? Which procedures you can do? So there are two procedures, that is step TAPP and TAP TEP. That is trans-abdominal pre-peritoneal procedure. One is, and another is total extra-peritoneal procedure. So name itself suggests that trans-abdominal, we are going through the abdomen to pre-peritoneal space. So we are going to abdomen, and then in peritoneum, we are piercing peritoneum and going to pre-peritoneum. That is TAP, TAPP. And what is TAP? That is total extraperitoneal. We are not going to the peritoneum. We are not piercing the peritoneum. We are not going to the abdomen. That is TEP. So that is the basic difference. Otherwise, all steps, everything, all dissection, the place to put the mesh, everything is same in both the things, right? Just differences. In TAPP, we are going through the abdomen to the preperitoneal space. In TEP, we are directly going to the preperitoneal space. Here I have put two, three figures, which will show you. This is TEP. We are going from the rectus. We are putting incision into the anterior rectus sheath. We are going between the peritoneum and the posterior, between the rectus sheath and the peritoneum, and we are approaching to the hernia side. In TAPP, we are going to the abdomen first, intra-abdominal we are going, and then we are piercing peritoneum and coming back to pre-peritoneal space. That is TAPP. This all figures are showing same thing. If you can appreciate, you will have PPT later, so you can study later. So that was the basic difference between the only difference, not basic, but the only difference between TEP and TAPP. Another difference, not only, but another difference is the port site. Which port will we select in TEP and TAPP? The port for TAPP is 10 port will put on the umbilicus. That is the camera port. The another two 5 port will put on the pararectus area on this right and left side. So we can approach both the inguinal region. In the TEP, we are first of all we are putting incision on the umbilical area, anterior rectus sheath, making space between the rectus abdominis muscle and posterior rectus sheath. Over this side, we are going under vision, and then after in lower one third there is no posterior rectus sheath. So you'll have a peritoneum and the rectus muscle right directly. So you'll be reach in the pre-peritoneal space directly. So we are putting first of all 10 camera port will put, and after that under vision will put this 5 port later on. Once you'll make the pre-peritoneal space. This 5 port just above the pubic symphysis, or 5 above 5 centimeter above the pubic symphysis, and the another one is between the umbilical and the lower port. Right, these are the port sides. These are the two basic difference between TEP and TAPP, basic and only difference. I am again saying, otherwise dissection is same, and where you have to put mesh is same. What are the complication is almost similar, because you are going to operate in the same area for the both the procedures. So this two basic difference you have to remember, right? So now I'll discuss about the trans-abdominal pre-peritoneal procedure, that is TAP. In that, what you will do, that port created, as I said, 10 umbilical port for the laparoscopy, 5 port placed on the each side of the pararectal point, at or above the level of umbilicus. You can put on the same line or above the umbilicus, the pararectal ports. For TAPP, conventional laparoscopy is performed. That is basic laparoscopy as we are doing. We are going into the abdomen. That is why it is called conventional laparoscopy for TAPP. Then once you are reached into the in the abdominal cavity, what will you do? You have to, your target is to reach into the preperitoneal space. So to reach to the preperitoneal space, now you have to reach at the point, or you have to decide one point from where you can enter into the preperitoneal space. That should be a safe point, right? And the point from where you can dissect easily, that should be that point. So what is that point is? So that is the preperitoneum. The peritoneum is divided and beginning at the medial umbilical ligament, just about 2 centimeter above the hernia defect, and extending laterally horizontal direction towards the anterior superior iliac spine. That is the line of inguinal ligament. So here you can appreciate this is median umbilical ligament. That is the center ligament, right? From center, you will dissect. If it is on the right side, you will dissect on the right side. If it is on the left side, you will dissect on the left side. And your approach should be parallel to the inguinal ligament, right? 2 centimeter above. Why? Because you will have superficial and deep inguinal ring, and you will have an excess in that 1.25 to 2 centimeter. Between that area, you will have an excess. So you'll go 2 centimeter above, you'll start putting an incision just lateral to the median umbilical ligament in the line of inguinal canal, right? Inguinal ligament. That is the horizontal incision. A radical dissection of preperitoneal space is then accomplished, exposing the inferior epigastric vessel, Cooper ligament, and the symphysis pubis. Why? Because the you if you have read the proper hernia, then you must be knowing medial and lateral. The inferior epigastric vessel is important. Lateral to it is indirect inguinal. Medial to it is direct inguinal hernia. So you should expose this inferior epigastric vessel so you can appreciate hernia is coming from sac is just only over here, or it is coming from lateral to it. So it is indirect only, or direct and indirect both pantaloon hernia, or it is just indirect inguinal hernia. So you're exposing inferior epigastric vessel for that. You are exposing Cooper's ligament, right? And the symphysis pubis. Symphysis pubis, we are fixing the $1 million stitch, first stitch for the mesh. We are taking in open surgeries with the pubic symphysis. So you should be opening clear. The symphysis pubis should be in under vision, under your vision. So it should be open. And the Cooper's ligament. Why the Cooper's ligament? Because you should not miss the femoral ligament, or femoral hernia, or myopectineal orifice of Frochard should be open. You all the hernial site should be under vision, that you are not missing anything, right? So Cooper's ligament, this and inferior epigastric vessel and symphysis pubis should be open. It should be clear under your vision, so you can repair properly. So once you have exposed all these things, what you will do now? Now you will identify which type of hernia it is. Then you will reduce that hernia. You will reduce the content. Direct, indirect, whatever it is, you will reduce the content now. So it is important to adequately mobilize the inferior peritoneal flap away from the internal spermatic vessels and the vas deferens. To prevent the roll-up of prosthesis is when peritoneum is eventually closed. So once you have reduced the content, now what you should do? So this are the vessels passing from below the inguinal ligament and iliopubic tract. These are the spermatic vessels, vas deferens, and testicular vessels going from the deep inguinal ring. The spermatic cord content are going inside the inguinal canal from the deep inguinal ring. Now, if you are not exposing this pre-peritoneal space adequately, if this space is not open adequately, what can happen? Just think what can happen if you have not opened it up properly. And you are putting mesh over here, and now you are closing this flap, this peritoneal flap with this mesh will get roll up. Like if I can make you understand, if this is the canal, this is the mesh, this is the peritoneal flap, you are closing with this, and you have not exposed this peritoneum adequately, what will happen? It will get roll up. So mesh will move. It won't be remain on the proper side. The femoral canal or myobacterial orifice of Pochard won't be covered completely. So patient will can have chances of recurrence, can have chances of another hernia like a femoral hernia in future, right? So you have to open the flap, inferior flap of peritoneum adequately and put the mesh properly and close it properly later on. That should be in your mind. So dissection now after this, one thing you have to keep in mind is inferior flap should be open adequately. What another thing you have to keep in mind doing laparoscopic surgery is dissecting inferiorly and lateral to the iliopubic tract. This is the iliopubic tract. This is your iliopubic tract, right? I'm marking it. Hope you are able to appreciate it. So lateral and inferior to the iliopubic tract. This is lateral and inferior to the iliopubic tract. What you are having in this big image, if you are appreciating, this is iliopubic tract. On laterally and below you are going. These are the huge large vessels and nerves are over here. So while dissecting, you have to take care of this area. So first of all, identify iliopubic tract and don't go much lower lateral and downwards from the iliopubic tract. Otherwise, you are entering into the area of doom. Doom means death, area of death. So you are damaging the large vessels like external oblique vessels and the femoral nerves. You are damaging that. So in doom, if you are entering, you are damaging large vessels, and if you are damaging the major nerves like a femoral nerve and its branches, then patient will have severe pain in post-operative period. So you have to take care of these two areas while operating. So you don't you have to take care while going laterally and downwards from the iliopubic tract. You have to take care while first of all while dissecting, second while putting the mesh. After putting the mesh, you have to avoid putting tackers and sutures over this area. So you have to take care that you are not entering into the area of doom and pain. That is important, right? So after dissecting, after reducing the hernia, what thing you will do? Now you have a clear area, you have dissected adequately, you have take care of nerves and vessels. So now you'll put the mesh. Most surgeons will choose the large mesh, that is 15 by 10 centimeter size mesh, that is Proline, Wipro, Ultra Pro. Multiple different meshes are available in the market. So surgeon will choose accordingly, according to their choice and according to the patient's fitness and different patients. They'll put that mesh in the pre-peritoneal plane, of course, because we have entered into the pre-peritoneal plane for the same thing, and we have reduced content, and we'll put the mesh in pre-peritoneal plane, and then we'll close that pre-peritoneal space, that peritoneum layer wise, we'll close the peritoneum and will come out after that. So most surgeons now prefer larger prosthesis and fewer fixation with the text to lessen the post-operative pain. Of course, more manipulation you'll do, more the pain patient will have. More the stitch are there, more the pain will have, and more the tackers, more the pain. Right. So we'll put the less stitch, less tackers to lessen the pain for the patient. Care should be taken to avoid the triangle of doom, as I already said, site of femoral vessels medially and inferior to the iliopubic tract, and the triangle of pain, site of lateral cutaneous nerve of thigh and branches of genitofemoral nerves, literally inferior to the iliopubic tract. Indirect, now we are done with the procedure. We are now discussing few points. Like indirect sec is more difficult to deal with because of the difficulty in separating them from the cord structure. In the direct sec, it is coming from the posterior wall directly, so it is not getting attached, or it is not, we are not needed to separate it from the cord much in that case, as well as in the indirect case, because in indirect hernia it is coming from the deep ring with the spermatic cord, along with the spermatic cord. So sometimes you'll find that spermatic cord and sac will be very adhere. So you have to dissect sac from away from the spermatic cord, and you have to take care. So it is difficult. Indirect sac is, especially in the chronic cases, in the patient with the long-standing hernia, it is quite difficult. In the large inguinoscrotal sac, what you are not needed to excise out whole sac. You can proximally excise the sac. You can transfix it, put it in the into the abdomen back, And in distal sac, you can cut it wide open and keep it same, just to prevent the incidence of hydrocele and vascular disruption. Nowadays, we have robotic modifications also. Many not in that is not used in India much, but in outside India it is used nowadays. Even in India, there are few places the robotic modifications are used. It is easy to use because they'll have a good access, more instrumental and three-dimensional optics and everything. So today we are just focusing on the laparoscopic surgery. So I have just kept one point over it. So now from TA, this was about TAPP, that from intra-abdomen to pre-peritoneal space, put a mesh, fix it, ligate the peritoneum, come out from the abdomen and close the umbilical port sides, right? That was TAPP. Now TEP, total extraperitoneal repair. As I said before, just two difference. One is going extraperitoneally only, and another is we are going from extraperitoneal, and another is we are just putting going extraperitoneal and put the mesh. We are not a port side. The port side is in the one line, that is the medially only, median on the median line only. We are not going to the pararectal side, right? So in total extraperitoneal, the incision is made over the umbilicus. The rectus sheath is open on the one side. The rectus muscle is retracted laterally. I have one figure. In this you cannot appreciate, but if you can, we have put the median incision. We are putting rectus muscle, pushing rectus muscle laterally and going inside, making a space between the rectus muscle and the posterior rectus sheath, with or without using dissecting balloon. Few surgeons use the dissecting balloon, few don't. Once the space is large enough, two additional cannulas are placed in the midline, one approximately 5 centimeters above the pubic symphysis, and one in midway between the lower and the upper port, that is between the umbilicus and the pubic symphysis. The dissection of the preperitoneal space is completed under direct vision. So here you are going between the rectus muscle and posterior rectus sheath, but after some point you won't have posterior rectus sheath, so you will be just directly between the peritoneum and the rectus muscle. So here you have posterior rectus sheath, but now you won't have posterior rectus sheath, so you are between peritoneum and rectus muscle, that is preperitoneal space directly under vision, and you are putting port under vision, right? And this is the balloon. I have shown few surgeons use balloon, few don't use the balloon. Few directly put the trocar. So dissection of the preperitoneal space is completed under direct vision. The rest of the procedure is like TAPP only. Like you have to take care of that nerve vessels. You have to see all myobacterial forechards area. You have to identify direct, indirect sec. You have to reduce it, and you have to put the large mesh, that is 15 by 10 centimeter mesh. And you have to put the tackers, and while putting tackers, you have to take care of this vessels. Although literatures are favors TEP, as you are avoiding entering into the abdomen, you are avoiding this peritoneal cavity manipulation, vascular injuries, adhesions, and everything. But there is no sufficient data saying that TEP is better than TAPP. The choice is largely based on the surgeon's comfort. Whichever surgeon is comfort with whichever procedure, they'll go with that only, right? So this is the photograph I have already discussed. I have already make you understood. This is the mesh we are putting. I have kept both the pictures so you can understand easily. This is iliopubic tract. Iliopubic tract. You are covering this area and above as well. This is indirect space because ring is over here. So you are covering indirect, direct space, and below you are around the femoral vessel. You are covering this femoral hernia also. But and you can appreciate that in this area you haven't put any, in figure there is no any stitch, no any staple, no any tackers, because vessels are over here. You have to avoid putting staple over here. You are putting staples over Cooper's ligament, or this medial symphysis pubis and above, but not on epigastric vessel around it, right? So preventing all damage to the vessels and nerve. So what are the complications of the surgery? Intraoperative, you can damage the blood vessel, inferior epigastric and femoral, so you will have blood. You can damage bowel and bladder because you are going in TAP only. because BAPP, sorry, because you are going through the intra-abdomen. Injury to the ilioinguinal and iliohypogastric nerve can occur. Injury to the cord structure as well can occur, because while dissecting indirect sec from the cord, you can damage cord structures as well. What are the post-operative complication? Urine retention, of course, hematoma, because if there is any oozer or bleeding is there and you are not able to close it or appreciate it, it can cause hematoma later. Infection, any surgery can cause infection later. So as well as this laparoscopic. Peritonitis of periostasis of pubic tubercle, as you are manipulating pubic tubercle by taking a first stitch. Post herniorrhaphy hydrocele can also occur due to collection, or if you have not dissected sac properly or open it properly, it can cause collection or hydrocele formation in later. What are the late complication? Late is recurrence. If you have not put proper mesh has been displaced, or closure has not been done well, so recurrence can occur. As I said previously, testicular atrophy, if you are damaging the testicular artery or ligating the testicular artery at the same time, it can occur, and obstruction can also occur. If you have you can have post-operative in TAP due to manipulation of bowel or intra-abdomen. You have in post-operative adhesions can cause obstruction, post-operative adynamic bowel obstruction. Also, if you have uh, any damage to the any nerves, or while operating, if you have tied or ligated. So there are a few cases surgeons have also perforated the bowel during intraoperatively and can cause intraoperative bowel perforation also, that we have to operate immediately. So that was perforation was intraoperative, and later on also patient can present, right? So that are the complication of it. Laparoscopic hernia repair complication in general, as I said before, same thing. Vascular injury, it is same thing, but in short, I have explained it again. Vascular visceral injury, trocar site complication, like again, if in trocar site, if you have not closed the port site properly, it can cause the incisional hernia later on. Bowel obstruction, as I said, hypercarbia abdominal compartment syndrome can also occur if you have not closed it properly. So now jumping, this was all about the groin hernia repair with the laparoscopy. Now we'll go to the abdominal, anterior abdominal wall hernia, that is umbilical epigastric or hypogastric spigelline hernia. For that, you should be knowing where to put the mesh and what it calls. So between two muscles, in if you are, this is anterior, this is linea alba over here. If you are putting mesh between these two muscles, that is inlay. If you are putting mesh above both the muscle, above the anterior rectus sheath, that is overlay, onlay mesh plasty, above the anterior rectus sheath. If you are putting mesh below intraperitoneally, that is underlay. If you are putting mesh between the rectus muscle and posterior rectus sheath, that is retrorectus, or you can say that is posterior rectus sheath. If you are putting mesh behind the posterior rectus sheath but preperitoneally, that can call sublay also, and intermuscular sheath can also mesh can also be kept, right? These are the types of mesh we are placing, and it is named by this name as per the site of the mesh we have kept, right? So now we are going to discuss about intraperitoneal onlay mesh plasty. uh, why it is called onlay when we are putting it intraperitoneally? It is a misnomer. Onlay is a misnomer for this procedure. As in open surgery, we are putting mesh on the anterior rectus sheath. We are calling it onlay mesh plasty, as we are seeing it directly, and it is just above our vision, just in front of our vision. Same thing while doing intraperitoneal mesh plasty. We are putting mesh below the peritoneum, that is directly in front of our vision in under camera. So we are calling it onlay. It is a misnomer. It is inlay actually, but we call it onlay because it is directly under our vision, right? On the very first layer we are putting it. So there is IPOM and IPOM plus. There are two procedure. The IPOM is intraperitoneal, just we are reducing the content and we are putting mesh, that is IPOM. But if we are closing the defect and putting mesh, if we are doing both the things, that is called IPOM plus. We are we are adding something in this putting mesh. We are fixing the defect and putting the mesh, that is IPOM plus. So I'm not writing IPOM plus IPOM and IPOM plus. I have just kept IPOM, but do understand when I say that we are closing defect.
Sorry, ma'am, to disturb, ma'am, we can't hear you. Excuse me.
Ma'am, we can't hear you, ma'am.
Excuse me, ma'am. Ma'am, we can't hear your voice.
I think there is a network issue.
Ma'am, can you just like connect to the audio and like disconnect first and connect the audio again once? Members, ma'am is just joining again. Just kindly wait for a few seconds.
Do let me share my PPT.
Yes, ma'am. Just a second. Yes, ma'am. Can you do it, ma'am?
Yeah, 1 second.
Yes,
Am I
ma'am.
audible
Yes,
now?
ma'am. Yes, ma'am. Yes, ma'am.
So I
Yes,
should
ma'am. Yes,
start
ma'am.
from IPOM or I should.
Ma'am, from IPOM,
You have understood this
IPOM plus,
thing, right? This
Yes,
underlying,
yes,
you have understood that thing, right?
yes,
Yes,
yes.
yes.
So I'm starting from IPOM again. So IPOM is intraperitoneal onlay meshplasty done for, hello?
Yes, ma'am. You can continue, ma'am.
Okay. So IPOM is intraperitoneal onlay meshplasty but it is only is a misnomer for this procedure. Why? Because when you are putting mesh intraperitoneally, you are calling it underlay, right? Intraperitoneum is underlay inside the peritoneum. But as in open surgery, as we are seeing directly a mesh over the anterior rectus sheath and we are calling it onlay, in this laparoscopic surgery, we are putting mesh under direct vision of camera just below the peritoneum, right? That is why we are calling it onlay meshoplasty. When you are doing only this IPOM, there is two name, IPOM and IPOM plus. When you will call IPOM plus, when you are closing defect and putting mesh, it is called IPOM plus because you are adding one procedure to putting mesh. It is IPOM plus. And if when you are not just closing, you are not closing the defect and you are just reducing it and putting directly a mesh, that is only an IPOM. I have not write it IPOM plus over here. Just do consider it whenever I am saying that closing a defect, it is called as IPOM plus procedure. So keep that in your mind that it is IPOM plus procedure. I am explaining it. I am explaining both things simultaneously. So when there is an anterior abdominal wall hernia, we can close it laparoscopically and do it open inlay meshplasty. That is open underlay inlay meshplasty we can do, right? But today we'll discuss just laparoscopic procedure. So what are the indication of laparoscopic intraperitoneal onlay meshplasty? So when there is a ventral wall hernia, ventral hernia, recurrent hernia, or incisional hernia over the anterior abdominal wall, we can choose this
Mm. Sorry, ma'am, to disturb again. The voice again went off. Mm. Ma'am, can you hear me?
hello.
Yes, ma'am. Yes, now you're audible.
Please do let me share my content. There's some network issue. Sorry, everyone.
Yes, ma'am. You can share it.
Do cooperative. Uh, should I start with the indications or I should start again from?
Yes, ma'am. From indications is fine.
Okay. So there are so indications of anterior abdominal wall hernia for laparoscopic surgery is ventral hernia, recurrent hernia, and incisional hernia. Ventral hernia includes that umbilical, epigastric, and subgastric hernia. That is ospigillin hernia, you can also say. Incisional hernia, like you have done laparoscopic surgery for the cholecystectomy or appendicectomy or this inguinal or groin hernia, and you haven't closed that umbilical port side properly, it will have incisional hernia, or any other abdominal procedure, post-abdominal procedure, you can have incisional hernia. In that case also, you can choose this laparoscopic surgery. So, what should be in your mind while choosing patient for laparoscopy? That is, the gap defect should not be more than 5 centimeter, because while putting a mesh should be more into two times. Like if there is a 5 centimeter gap defect, there should be 5 centimeter strengthening more mesh over right and left both the side, and above and below as well, to give the strength to the repair, to the strength to the defect around the defect area. So if there is a 5 centimeter defect, mesh should be 15 by 15 centimeter size, right? So defect should not be more than 5 centimeter for the laparoscopic surgery. Otherwise, you have to go for the open repair. You have to do a transverse abdominal release operation, or you have to do another major open operative procedures for the more than 5 centimeter defect. What are the contraindication for the lap IPOM surgery? When you won't choose this patient for the laparoscopic surgery. So patient with the cardiorespiratory compromise, patient pregnant female, because in those patients you are using CO2, it will be harmful to the patient. Patient will have more cardiorespiratory difficulty. Fecal peritonitis, gangrenous bowel, intra-abdominal sepsis, all those dirty wounds, dirty OT, you should avoid the laparoscopic intra-abdominal mesh repair, because you don't need to put mesh while you are doing hernia repair in this dirty wound. Even in open small procedure, if there is a dirty wound, you are not putting a mesh. You are just doing a Rafi procedure. You are just strengthening the wall. So you are not needed to do a mesh repair. Large defect with the loss of abdominal dome and contour, also you have to avoid it, because you need the abdominal wall repair also. Uh, Pediatric patient and liver cirrhosis patient also, you should avoid this laparoscopic surgery. So what are the pros and cons of this laparoscopic ventral hernia repair? The pros are, accurately you can identify all the facial defect by the laparoscopy. As you are going intra-abdominally, you can visualize whole abdomen. Wherever there is a small defect, you can close it. You may identify unsuspected intraperitoneal pathology as you are going inside. If you are not going inside, if you are doing umbilical hernia repair from outside, you are doing onlay meshplasty or sublay meshplasty, you are not going intra-abdominal, so you won't be able to identify the intraperitoneal pathologies. In this, you have that benefit. Approaches fascia through the clean field. So we are going through the clean field. You are not using the dirty field. That is also an advantage. But the cons of it, it is not possible to revise the contour of abdominal wall. So in case of this large defect or loss of abdominal contour, you are not able to revise it. So patient will have that loose contour again. So you won't choose this patient for lap surgery. Adhesiolysis may be difficult with the increased potential for enterotomy. So while doing adhesiolysis, you can potentially damage the bowel. As I said before, you can perforate a bowel, and intraoperative perforation means enterotomy can happen, and you have to repair it. Hard to get good fixation for defects at margin of the abdominal cavity. At margins, it is difficult to close and fix the defect. So what is now, we'll jump to this was about the indication, contraindication, and pros and cons of this surgery. After discussing it, when you are doing IPOM, what is the OT step, how you will keep the patient, where you will put the ports, that you have to discuss now. So in operative procedure, patient will be given supine position with the head low and leg low position. So patient will be in this position. After that, after giving a position, where you'll put the ports and how many ports you'll use. Generally, surgeon use 3 ports. Fourth port is kept SOS for the good, better ergonomic purpose. So routinely, surgeons use this 10 port, camera port at the anterior axillary line. At the level of umbilicus, in the anterior axillary line, we'll put the 10 port. Another 5 port in the left upper quadrant, and another in the left lower quadrant. We here in this hospital, we are using another 3-port surgery. That is, we are putting one port over in the left upper quadrant, 10 port in the epigastric region, and one more port in the right upper quadrant. So we can have a direct vision towards this defect, right? So we are using this 3-port in these days, and these 3 ports are also ideal to do the surgery, as I mentioned over here. The additional port, if you are needed, you can put, if you are operating from the right or left side in opposite direction, you can put parallel to the umbilicus and anterior axillary line, 5 put additional port you can insert. So what are the steps of this procedure? So you can go inside with the Veery's needle or Hessen's open technique, or by the direct trocar entry, you can insert into the abdominal cavity. After getting into the abdominal cavity, you should assess whole abdomen under camera vision. Look for the gap defect where it is. Look for the content of hernia. Is it a bowel, or is it a omentum, or what the content it have? And surrounding structures you should see. After that, you have to do adhesiolysis and reduction of content you should do. Measure the defect with the low intra-abdominal pressure, because in high abdominal pressure, the muscles will be stretched. So you'll have, if you have a 3 or 4 defect, you will have a larger area. You won't be able to measure it properly because the dome will be tight. So measure the gap defect in the low intra-abdominal pressure, remove out the gas, and then measure the defect. After that, once you have measured it, suture the defect now. Reduce the content, and after that, suture the defect. That is IPOM plus procedure. You are plus adding something. So suture the defect, suturing it with the non-absorbable suture now. After that, take a sac bite to prevent the seroma. During, if there is a large sac, you should excise it and ligate it, transfix it. And if it is a small, you can put it directly inside, right? And defect closure should be in at low intra-abdominal pressure, as you have to measure it at low intra-abdominal pressure. Closure should be at low intra-abdominal pressure. After closing the defect and reducing the content, re-insufflate the abdominal cavity now, because now you have to put the mesh inside. So re-insufflate it. You'll need a more space to put the mesh. So mesh placement will take place now. So in laparoscopic ventral hernia repair, the mesh is placed in direct contact with the viscera. As in the open inlay repair, as I said before, as in the open inlay repairs, this carries the risk of development of chronic inflammation, fistula, infection, and mesh migration later on. To minimize this risk, dual side mesh prostheses have been developed now and should be utilized in laparoscopic ventral hernia repair now. These implants are coated with the materials designed to prevent the adhesion formation and the side exposed to the viscera. So nowadays we have a mesh which is preventing adhesion and infection chances with the viscera in these days. So absorbable material will be towards the viscera and non-absorbable towards the peritoneum. So we have this composite mesh in these days we are using. Mesh should cover 5 centimeter of normal tissue surrounding the defect, as I said before, and that is why we are choosing patient with a less than or equal to 5 centimeter defect. 4 corner transfacial sutures are taken, or 4 corner or 4 center we can choose. 4 corner, generally in book they have mentioned 4 corner transfixation sutures. Here this is our operative field. We are taking this 4 corner or 4 center transfixation sutures we are taking. We will mark on the abdomen first while patient CO2 has been taken out. It is not re-insufflated. At that point of time, you are putting this mesh, taking mesh over here, and you will put the mark. So once you are inside the abdomen, you are knowing that from outside, from where you have to go directly inside and where you have to fix it. So we'll do marking. We'll put this 4 stitch transfacial sutures. So transfacially from, as I have put suture over here, I'll go transfacially from this side. So exact on the same side, I'll go inside. It won't happen like I'm going from here and suture is over here, or suture is over here and I'm going from this side. So mesh should not be moved from one side to another side. It should be on the same side. Note should be on the same side. It should not be away from the transfacial plane. So for that, we are doing marking and taking notes. Suture to fix mesh intracorporeal suturing with the non-absorbable sutures like Prolin 1 number is done. Crowning stitch is taken first in the center, followed by periphery stitch is taken. Tackers are now available. Double crowning at 1 to 2 centimeter apart is done. We are using tackers. First central tackering done, and then peripheral tackering is done. So first of all, take transfacial sutures, then re-insufflate, put the mesh inside, re-insufflate the abdomen, tie the transfacial sutures, one in this side, this side, this side, this side. So this 4 sutures are taken at the first time, or 4 corners or 4 central sutures. This are taken first. After that, what you will do? After that, you will do this tackering with the tacker. This is the tacker in my hand. Gun like a structure, go from the abdominal port, one of the 5 port, go inside and do a crowning. First central tacking and then outer peripheral tacking. It will look like a crown, right? That is why it is called a crowning. So by that you are fixing the mesh. Momentum will remain between the mesh and bowel, so the mesh won't directly in contact with the bowel. So prevent the adhesions. Policeman, as always, momentum. A sheath closure is done at the camera after doing this tackering. After the tacking the mesh, you are coming out. You are looking for any other complication, or if there is any enterotomy has happened, or if there is any complication inside the abdomen. If it is not, if it is clear, mesh is capped properly, tacking is done properly. Put the momentum over the bowel and just come out under the vision. Take out all the ports. Just fix the sheath closure done at the camera port. As you are gone through the sheath, you have put the 10 mm incision. So close the that side properly. Skin closure done with the 20 Vicryl in vertical mattress, as done in the other CLW and other procedures. What are the post-operative management needed for this IPOM patient? This was the OT procedure. Now post-op care is also important. So as we have not manipulated bowel, we have just kept mesh and done laparoscopic procedure under GA. So we'll wait for 4 hours, and after 4 hours, as bowel has not been manipulated, you can start oral fluids to the patient, followed by diet in a few hours. That is 6 to 8 hours. We are starting diet to the patient and ask patient to ambulate. Start chest physiotherapy as done in all laparoscopic surgery and all GA procedures. Give IV antibiotics to prevent post-operative mesh infections. Pressure dressing over hernia site is done. There is a outside bulging of, you are not able to give abdominal contour, just do pressure dressing over the hernia site. So you will have a proper abdominal contour. You have better healing. And you can discharge patient in 48 to 72 hours if it is vitally stable. As you have started diet, patient is ambulatory, vitally stable, you can discharge patient in 48 to 72 hours. What are the complications of this procedure? So it can be intraoperative, postoperative, and late postoperative complication as in any other procedure. So what are the intraoperative? So it can be a trocar injury. First of all, while putting a trocar, you can injure viscera or vascular structures. Postoperative seroma can happen, wound infection can happen, and postoperative paralytic ileus can occur. What in late postoperative complication, port site incisional hernia can occur if you are not closing port site properly, right? And recurrence can occur. If you have not closed port site properly, recurrence or incisional hernia can occur. So what is the conclusion of this IPOM or IPOM plus? Overall incidence of postoperative complication has been decreased, obviously, as it is a laparoscopic hernia repair. Wound-related complication also be decreased, but short-term pain and quality of life appear to be similar in the open and the laparoscopic procedure. But hospital stay and return to workup is better with the laparoscopic procedure. So patients are nowadays going for the laparoscopic repair. Surgeons are choosing laparoscopic repair in comparison to the open surgery. Thank you everyone for listening me, and sorry for the inconvenience in between. Thank you for listening me. And if you have any query, you can put into the YouTube comment box. I'll reply it later. Thank you so much.
Thank you very much, ma'am. It was indeed a very intense and a deep session about from step each step of the laparoscopic surgery. And ma'am, there are like a few doubts in the chat section. Like one
Yeah.
doubt was like, is there any advantage of open hernia repair over laparoscopy repair? That was
Yes, of
one.
course. That's why it is, as I said before itself, that in open hernia repair, you are having a big incision, right? In open hernia
Yes,
repair, a large incision. You
yes,
have
ma'am.
more chances of recurrence. You have to close all layers. So if there is any defect in any layer, you can have incisional hernia later on. Or second thing, you have more chances of wound infection as the wound is bigger. So wound infection chances will be more, while that will be lesser in this laparoscopic hernia. In laparoscopic hernia, patient will be mobile immediately, or in some time you can start a diet in some time. Same in the open surgery as well, but in laparoscopy, patient will be have a lesser pain, small wound, less chances of infection than the open surgery. So it is better.
Okay, ma'am. Mm, That's it for the doubts. Even on the YouTube, there aren't any much doubts over here.
If anybody have a doubt, they can put into the comment box on the YouTube. I'll reply it later on whenever
Okay,
I'll be free.
definitely. Thank you very much, ma'am, for your valuable time. I indeed feel that everybody will be very much benefited by the session. And thank you, one and thank you, ma'am.
Welcome. Welcome.